Hi, I'm Katy Ellis. I'm a nurse consultant at Manchester University Foundation Trust. I'm going to talk to you today about my pre-doctoral fellowship experience and my research idea, which is the management of breast pain as a solitary symptom. So I'm going to talk about how the journey has been so far, the research idea, where that came from, the internship that I undertook with the NIHR a couple of years ago, my experience during the pre-doc fellowship and what I've achieved, any challenges that I might have had, and finally what's next. So my research idea is looking at the management of breast pain as a solitary symptom. So what we do know is that breast units are overwhelmed with referrals, and in the last 10 years we've seen a 100% increase in referrals into breast units. We also know that whilst there's been a 100% increase, actually the relative rate of increase of cancer is nowhere near that. We also know that breast pain is a really common symptom, and we think around somewhere in the region of 70% of patients will have breast pain at some point in their life. We also know that there's a lot of patients that are referred into secondary care with breast pain, and we think the referral rates are somewhere in the region of about 20%, but the figures stay anywhere from 13 to 50%. We know that patients often worry about breast pain because they think it may be linked to breast cancer, and that's one of the big reasons patients do attend their GP and then obviously get referred into us in the breast clinics. But we also know that it is unlikely to be linked to breast cancer, and actually the literature so far suggests the incidence of breast cancer with somebody with a solitary symptom of breast pain is around 0.4%. We also think that musculoskeletal disease is more commonly the cause of breast pain, and actually it's not a breast problem, but it's actually inflammation of the chest wall, which is behind the breast, that's causing the problem. So what we wanted to have a look at is whether we can provide an alternative to the one-stop clinic. So a one-stop clinic is where a patient is referred into a breast unit, and all breast units will run a one-stop clinic where we have an opportunity for a consultation, examination, any radiological imaging, which may include mammography or ultrasound scan, and also a biopsy. So they're quite expensive clinics to put on, with obviously very experienced staff that are performing all of these investigations. So in 2020, when COVID hit, I think we all looked at how we could manage our services differently, and we had to really scrutinise what we were doing. And certainly in breast care, what we had to do was prioritise those patients that had red flag symptoms to make sure that we were seeing the ones that were more likely to have breast cancer. So that meant that we had patients with breast pain that unfortunately had quite a long wait to be seen. And actually what we decided in the end was that we weren't going to be able to get these patients into a face-to-face appointment, that we needed to do something different. So we created a telephone assessment clinic, and we assessed these patients over the phone to ask them about their symptoms. But knowing that this was a little bit of a new way of looking after these patients, we thought the best thing to do would be to collect some data and make sure that what we were actually implementing was safe. So we collected data on 1,238 patients, and actually when we analysed that data, we realised that our incidence of cancer in that group was about 0.5%, so in keeping with what we had in the literature. But we also recognised there were a lot of similarities in the way patients presented with that pain, and people would often describe it in the same way. We wanted to kind of have a look and see whether there was anything that we could do to perhaps reduce the amount of referrals for breast pain that were coming into the service. So my initial plan was to develop a digital application that patients would be able to access, and they will be able to have a look at their symptoms, and maybe we could give them advice on how to manage it without the patients actually needing to go to the GP or certainly needing to come into secondary care. And I thought developing a digital application would be a great idea, and kind of had this grand plan of that's what I was going to achieve. I then applied for the internship with the idea that that's what I was going to be looking at. But actually we were way off that, and it was very early on that I realised that we were way off even considering looking at a digital application. There was a lot of work to be done before that. So what I actually concentrated on during my internship was looking at the data that I'd had got from the service implementation, analysing the data and publishing my work. And then on top of that, building up various links across healthcare and the academic world to try and kind of support me going forward. So the NIHR was really helpful in kind of certainly making me kind of look at where I was and taking a step back. And I think the really interesting thing is that you don't know what you don't know, so you go into this with really great grand ideas, and actually you know what you know, and you know what you don't know, but you don't know what you don't know. So it was really interesting to kind of stop and say, actually, yeah, I have no idea about that. That's maybe something that we need to look at. So I finished the NIHR and then had a year out. I was unsure at that point, still feeling a little bit anxious and still had imposter syndrome, and still felt that I wasn't really in the world of academia, and I didn't feel that I could kind of move forward really into the next phase. But in the end, I did feel confident enough to apply for a pre-doc fellowship, and really grateful that I was awarded that by the NIHR. So my pre-doc fellowship ideas were around qualitative interviews, that I wanted to kind of interview referrers about their referral processes. Why were they referring patients in? I wanted to do an audit of patient data, so looking at some of the similarities and the reasons why people may present with breast pain. I was interested in doing a systematic review of digital applications to see what was out there and what kind of things did exist for patients and whether the information in there was accurate or not. I wanted to do a patient questionnaire, and I wanted to do an audit of the referrals that came into the breast pain unit to see kind of what information was in there, and was there anything that we could have a look at from that point of view. And this where kind of my supervisors really were crucial, because what they were very clear about is what we can achieve in the time frame that we had, and I think it's very easy to kind of run before you can walk. So they were absolutely brilliant in kind of saying, no, I think that's too much, we need to kind of step back a little bit. They were able to kind of help me decide what was really necessary and what was the really crucial things we need to look at, what was going to be most useful to get information on. Obviously, my supervisors have a wealth of links in the academic world, and so that has been really, really helpful, that they've been able to put me in touch with all sorts of people to help going forward. They've helped me look at what should fall into perhaps the pre-doc and what maybe should fall into the PhD, and I think some of the things that I was looking at from a pre-doc point of view actually really should fall into the PhD. And most importantly, I felt that my supervisors both really understood me. They understood what my strengths were, what my weaknesses were, and that's really crucial in your supervisors. So I think it's really important that you have somebody that's really knows you and what you're about, because that for me has been crucial. So the pre-doc plan eventually was to undertake a systematic review of digital applications using the TEC framework, and also doing an audit of breast pain referrals to see what information we can gain from that. So I presented my systematic review of digital applications at the Breast Pain Society, and that was in Nottingham. And what I did was a systematic review of the digital applications using the TEC framework. We reviewed 46 applications on both Google Play and the App Store. 41% of those apps listed breast pain as a symptom of breast cancer, which we found quite concerning. And only 14% actually had an explanation of breast pain within the digital application. And we surmised that patients were unlikely to get any reassurance from an app, and therefore were likely to prompt a primary care consultation for reassurance. And we also found that the information within the apps was very inaccurate, conflicting or non-existent. So I think it shows that there is potentially a role for a digital application around breast pain in the future. But like I say, I think we're way off that. But it proves that patients are really not getting very accurate advice. I then went on to do a retrospective audit of patients who were seeing their GP with a solitary symptom of breast pain to kind of see what the journey was for that patient. So I looked at 1,625 consecutive referrals, and out of those referrals, 200 of those were for breast pain as a solitary symptom. And what we found was that 51% of patients who had gone to their GP had then been found to have an additional finding by their GP. So the GP had examined them and found something else. This prompted the patient to be referred into secondary care and undergo a whole load of radiological images, of which there was 234 individual radiological images performed for these 200 patients. And actually the outcome was that 96% of the patients were accurate in their findings, that they had no other findings in the breast other than a solitary symptom of breast pain. 3.5% of those patients had additional benign findings such as a cyst, which is not concerning for cancer at all. And 0.5% of those patients did have a malignant finding, but this was not identified on clinical examination by the GP or actually in secondary care. So our conclusion is that the 44% of radiological investigations actually potentially could have been avoided if the patient hadn't seen the GP in a face-to-face appointment. So there is something about looking at, you know, what happens when patients see their GP and how confident GPs are in examining patients, breast patients, and obviously referring into secondary care. So it's been a really interesting process, an awful lot of work, and there have been a few challenges along the way. Access to the funding is particularly challenging, and I would say that advice to anybody out there who is undertaking anything like this is, if you need funding for something, you really need to be on it straight away, because it can be quite challenging. Keeping on top of emails and sometimes changes in personnel, so if people are leaving, sometimes you might miss an email that says somebody's leaving, or there hasn't been an email, and so you're chasing people wondering who it is you need to ask this question of. So that can be quite hard when you push for time. But dividing your time between the clinical and academic world, and that's, everybody talks about that, and it's really peaks and troughs. So some weeks it'll be more focused on the academic side, and then other weeks things will be a little bit quieter and you'll be able to concentrate a little bit more on the clinical side. So I think it's just accepting that that is the case, and that will always happen. Particularly for me, I don't like mithering people, so I think, you know, emailing my supervisors all the time, I always felt like I was on the bag, but they want you to, they're busy people, they want you to keep reminding them of things if you haven't got back to them. So I think it's about just accepting that that's the norm. Be prepared to change your plans, and I think that was the big learning curve for me, that I'd come in with this grand idea and actually straight away it was like, no, that's not where we're going, we need to do something more. So bearing in mind that this is an iterative process and it will change, you will read things, overview things, and just change things as you go, which is the right thing to happen, but it just sometimes, if you're not keen on change, can be a little bit off-putting, I think. So what's next? Well, I am going to apply for a PhD. I'm looking at perhaps doing this next year, and it is going to be about understanding the role of breast pain in cancer diagnosis. So this will be a kind of mixed methodology PhD. So a big part will be looking at epidemiology. What is the incidence of breast pain in primary care? Because we think what the incidence is in secondary care, but what we need to have a look at is how many patients actually are attending primary care, because this could massively impact primary care, and perhaps reduce the amount of patients that end up in primary care, and obviously they're overwhelmed too. So how many patients turn up in primary care, how many are reassured at the point of seeing their GP, but how many are then obviously subsequently referred in. I want to do a qualitative piece of work, also looking at primary care clinicians and looking at their referral processes and why they refer in. So that's going to be quite a big piece of work, kind of really sort of sitting in the primary care field. And then finally, building on the pre-doctoral work, I'm going to do a prospective study, which is looking at primary care clinicians and how good that they are kind of finding normal breast results or breast findings. Because it is a challenge, and we know it is a challenge in secondary care. So I think it's really interesting that if we can have a look at that and see kind of actually what's going on and how confident people are at dealing with normal breast findings. So it's been really enjoyable process, and I'd like to thank the NIHR, and I'd like to thank all my supervisors for all their support. It's been a really great experience. Thank you.
Yeah, well done, Katy. That's fabulous. Again, loads of work. You've clearly achieved so much during your time with us. And another good example of a project that tackles a really important problem with implications for NHS resources, but also for women who understandably find this concerning, this symptom. Does anybody have any questions for Katy?
Yeah, it was like really fascinating, and quite a lot of my kind of thoughts about research questions at the moment are about kind of appropriateness and of services, and like how we are, what the service specifications are. And it just kind of made me think about, like, it feels like your work is focused on, you know, there isn't a service for these people, or there isn't an intervention. Is that how do we manage pain for women, is what my thoughts are, and that just because it's not cancer, are you thinking that there should be an alternative service for this problem, or that it should be managed by the individual? I wasn't quite sure when I was.
Good question. So there's the thing with breast pain is the vast majority of people who present with breast pain, their pain is often quite short-lived. It's not like a chronic pain, so it's usually an acute pain that usually settles by itself, often doesn't require any analgesia. Patients don't have any kind of loss of kind of activities of daily living, or patient kind of quality of life. It doesn't really affect quality of life. So for the vast majority of patients, these patients are just concerned about the fact that it might be cancer. So that's why it's kind of very resource kind of focused, because actually the vast majority of people do not require anything further. There are a small percentage of patients that we think have got chronic breast pain, but we actually think that those patients, the pain is not, well, we think almost all of the patients, the pain is not coming from the breast, but we think that small percentage of patients, there may be a specific muscle that's causing the problem. So part of my research is hoping, so we're linking in with physiotherapists to see if we can identify and isolate the muscle that might be causing the symptom of breast pain, even though it's not the breast that's the problem. Because if we can identify that for the people that have the very chronic problems, we can then look at management, which will be probably outside of my PhD, and probably it'll be the next thing we look at, if you like. I think what we need to do is establish the breast pain, like I say, epidemiology, the referrals, how patients are coming in, to try and deal with the large number of patients that actually don't have a chronic problem, and then we can start looking down at the chronic group who do have a problem and may need some further intervention. So yeah, absolutely, we will look at that at some point.
Thank you. Thanks for a great question as well. Andrew, you've got your hand up.
I have, yeah. Thank you, Katy. It was really good. The bit that stuck out for me for being quite interesting was when you talked about putting was it your internship to PCAP? You put it down for a bit and then came back to it again. I was just, what was sort of your kind of your main motivations for coming back, just out of interest?
Well, research is something. I suppose the other way of answering that is why didn't I continue? I suppose.
So yeah, that's probably a more positive way of asking this.
Yeah, it's just, I think, lack of confidence. I think it's when you've not been in the academic world, and I've been going. I'm old. I've been going for a few years, and so when you've had a career which has been very clinical and research has not really been a part of your day-to-day life, to then suddenly pick it up, you feel it's this balance between being an expert and a novice. So I might be an expert clinically, but a complete and utter novice when it comes to academia. So I felt completely out of my depth when I started the internship, and I learned loads and it was great. But at the end of it, I thought, well, I can't go and do a pre-doc. I don't know enough to go and do a pre-doc. And as my supervisor keeps saying, but that's why you're doing the pre-doc, Katy, because you don't know it. So that's why you're here. But I think that it's really, I think you do doubt yourself. Actually, have I got this? Am I capable of doing this? Is this something that I can move forward with? And actually, it's been a great process. I've learned loads, and I will continue.
Wonderful.
Good luck with the next bit.
Thank you.
That's great, and you've provided some really wonderful advice for everybody, Katy. It's fabulous to hear, and you're not alone. We talk a lot in our catch-ups about imposter syndrome. It's something that unfortunately many of us have in academia, and so you're not alone in that. It's just learning to kind of deal with that, and know that it's commonly felt. And you talked a little bit about how you decided what was in your PhD versus your pre-doc, which I know is a challenge. Do you want to talk a little bit about that, just about how you decided that?
I think it's mainly to do with what's achievable in the time. So I think that's one big thing. And I think some of the things that we talked about, perhaps being part of the pre-doc, such as the qualitative interviews, we decided that was a much bigger piece of work, that actually doing that within the pre-doc, we were going to struggle to get that done, but also that it really should be something that we put with it. It's so important, that part of the work, that actually we should be putting that in the PhD. So I think it was just a chat between the supervisors as should we do this, should we not? Actually, if you start it, you're probably not going to be able to finish it in the pre-doc time, and actually this probably is really important and something that should be part of the PhD. So I think it's just I think the supervisors are the people really that can help you decide that. And for me, I just got all these grand ideas and no idea how long things would take. But
Great. Oh, that sounds really, really helpful to have those chats with your supervisors. And I second what you said about just sending follow-up emails. Absolutely. Everyone's really busy, so don't be afraid to contact supervisors, myself included. And